Well, that was pretty spectacular. I feel like following that's going to be pretty hard, and now that I'm just going to show a case, I'm going to be a little bit more conventional and kind of boring compared to that. But what I'm going to show you here is another case where we really took advantage of using advanced imaging techniques to get at a very complicated problem. So this was a very challenging situation where we had a 40-something-year-old man who had a complete interruption of the thoracic aorta, and this is sort of his story. So he's 42-year-old when we first met him. A couple years prior to that, he'd actually already had his first stroke. And when you wonder why a 40-something-year-old man has a stroke, turns out it's because his blood pressure is in the 200s on a regular basis. And this is with medication treatment, so you can only imagine what his blood pressure is without treatment. So it turns out that he actually has something called coarctation of the aorta. And coarctation of the aorta is typically a narrowing of the thoracic aorta after the left subclavian artery takes off. And that's what he was referred to me for. So unfortunately, he's an undocumented immigrant, and he was sent to me with a CT scan that couldn't play. So I was left with the option of just basically taking him to the cath lab and trying to fix his coarctation. So, well, it's a little bit more than a coarctation. So what you're seeing here is this is a pigtail catheter coming from the from the right femoral artery and extending to the bottom of the lower limb of his descending thoracic aorta. And you can see it's a blind pouch. It really goes nowhere. And actually what you're seeing opacified here is a little bit of a collateral, because in order to get blood flow from the top part of his aorta down to his lower extremities, he's developed all these collaterals that sort of allow that blood flow. And then so this is coming from the right radial artery, and you can see some of those collaterals now opacifying. So you can actually see that there's no connection whatsoever between the top limb and the bottom limb of his aorta. You can actually see these kind of really strange-looking tortuous vessels. These are collateral vessels that have developed over the time since his birth to actually allow perfusion of his kidneys, his abdominal organs, his lower extremities, etc. So this is not a coarctation. This is a complete interruption. So what does this actually look like when we scan it? So finally, we found a player that could actually play his CT scan. This is actually what it looks like. So as I mentioned, it's kind of like a coarctation in that it comes off after the left subclavian artery, but there's a complete interruption. So there's a complete gap there. And actually what was interesting was, in full disclosure and confidentially, what we did try to do is just try to poke a hole through just blindly. That was not a good idea. And the reason why that's not a good idea is typically when we do that in a chronic total occlusion, we go from the beak, which you can see here, and a beak here. And you can see where that beak is actually heading. It's actually heading right into the left pulmonary artery. So if we were actually successful in poking a hole, we would have ended up from the top limb of the aorta into the left pulmonary artery, creating a very bad fistula, especially since this pressure is in the 200s. So thankfully, that didn't work. So at this point, well, what are our options? Do we send him for open heart surgery? Do we medically manage, or do we fix it in the cath lab somehow? So at this point, when we spoke to our cardiac surgeon, he felt like this was not a great operative situation. Now, what he can do is he can actually create a graft that will actually go from the ascending to the descending limb. Okay, that's one way of doing it. But actually to operate in this section is actually pretty treacherous, you can imagine, because everywhere around this area is covered with collaterals, small, large, microscopic ones. So he may be able to ligate the large ones, but the problem is that the small ones are the ones that are going to continue to bleed for about a week after the surgery, and could potentially create a very bad situation where the guy may continue to have to go back to the OR multiple times to deal with those bleeding issues. And so what he recommended was that we try to find a solution from a cath standpoint, and that he would be on backup standby in case we need him. So we did this in the hybrid operating room for him to be on standby for us, and this is what the setup looks like in our hybrid operating room. So in typical fashion, we used a rotational angiogram to really map out what we were going to do. So we had the CT scan in advance, but the rotational angiogram allowed us to create this image. And then once we actually had this image, what we did was we created regions of interest to allow our targets, because the most important thing that we wanted to do was we wanted to penetrate from the center line of the aorta below to the center line of the aorta above, because what we didn't want to do is to do this when we did a perforation. Because you can imagine if we did that, we would enter into extravascular structures, which is a polite way of saying killing the guy. So once we were able to do that, we took those regions of interest in the hybrid operating room and we began to create a perforation. So this is just checking our position, making sure that our region of interest are fulfilled to real life. And so what you can see here now is we've gone from the left radial artery and placed a snare in the proximal limb, and then this is an RF perforation wire. So this is a wire that we typically use in neonates to perforate through pulmonary atresia. And so you can energize it at minimal dosages to burn through a very small and thin structure. Works perfectly in neonates, kind of an ideal situation in this one. So using that, we were actually able to drive very carefully, burning through within the center line, all the way from distal limb to the proximal limb. And what we would do is intermittently, we would actually check our position by taking a picture, and then we would actually move our fluoroscopy angles intermittently to make sure that in multiple angles we were actually on track to make it through. So then once we actually did that, we externalized the Nikken wire by snaring it and then externalizing out the left radial artery. And that actually created a situation where we had excellent support. And then from there, we were able to move on and get a dilator across. Once we actually got the sheath across, we were at a situation where we were pretty much done with the case because all the hard part had been done. We took this Gore-Tex covered stent that's balloon expandable and deployed it. It's as simple as this looks. And now we've completely recanalized his thoracic aorta. So the very next day, his blood pressure was down to 120 on just 2 medications. He had minimal gradient on his transthoracic echocardiogram. So in this scenario, what we've done is we've taken this novel intraoperative 3D cone beam CT and image guidance method and allowed us to create a very safe way of actually perforating. People have reported doing this using laser, using Brock and Brown needles, et cetera, but those are all pretty manual and very much blind guidance. We think that this is a safer way to do this in using both the imaging guidance, but also using a very safe technique for perforation. I mean, we think that doing this will continue to allow us to push the forefront of things that we can do transcatheter that previously could only been done by open techniques. So, like I said, I was going to keep it very short. That ends our CME portion of the conference. As you can see, there's a lot of really exciting techniques and a lot of very exciting tools all across the medical spectrum, as well as outside the medical spectrum that we really think that all of us together in this room can work together to collaborate on by using the toolbox of our friends and our collaborators. Yeah.